Welcome to this Step 3 review on heart failure exacerbation. This video is brought to you by Roadmap to Residency. Heart failure questions on Step 3 are not really about reciting physiology. They are about reading the stem, deciding how overloaded and how well perfused the patient is, and then choosing the next best step, whether that is a water pill, a pump support drug, or a safe discharge plan. Our goal today is not to reteach heart failure from the ground up. It is to show you exactly how these stems are built and how to attack them quickly. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to read a heart failure vignette to nail down volume status before choosing any treatment, because that single read drives almost every answer. Second, we will match the treatment to the patient, choosing between water pills for the overloaded patient, inotropes for the failing pump, and pressors for true shock. Third, we will optimize the discharge plan, starting the medicines that actually improve survival and arranging the right follow-up. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to decode volume status before you do anything else. Start with the last line of the question. That sentence tells you what is actually being asked, whether it is the next best step, the best initial drug, or the safest place to send the patient. Once you know the question, go back and read the stem with that goal in mind, and you will stop drowning in the numbers and the history. Then anchor on the volume picture. Decide if the patient is wet or dry, and warm or cold. Crackles in the lungs, swelling in the legs, raised neck veins, and recent weight gain all mean the patient is wet or fluid overloaded. Cool limbs, low blood pressure, and confusion mean the patient is cold or poorly perfusing. That single read points you straight at the right answer, so train yourself to do it every single time. Strategy 2 is the diuresis, then decide mindset, and it organizes most heart failure exacerbation questions. First, diuresis the wet and warm patient. The most common patient on the exam is fluid overloaded but still perfusing, with an adequate blood pressure and warm limbs. For that patient, the right answer is almost always an intravenous loop diuretic, usually furosemide, to pull off the extra fluid and relieve the breathlessness. Be suspicious of choices that jump straight to powerful drugs before simple decongestion has even been tried. Second, save the pumps for the cold patient. Inotropes and pressors are for the patient who is not perfusing, with a low blood pressure or signs of organ hypoperfusion. When two choices are both plausible, the better answer usually treats the actual problem in front of you. Decongestion for the wet patient and perfusion support for the cold one. Strategy 3 is knowing when to reach for inotropes and pressors, because the exam wants you to use them only when the patient truly needs them. First, inotropes help the failing pump. When the heart muscle cannot push enough blood forward and the patient is cold and clammy with a low cardiac output, a drug such as dobutamine or milrinone increases the strength of contraction. The stem clue is poor perfusion with a blood pressure that is low but has not yet collapsed. Second, pressors rescue true shock. When the blood pressure is dangerously low and the patient is in shock, a vasopressor such as norepinephrine raises the pressure to protect the brain, kidneys, and heart. The stem clue is profound hypertension with cold limbs. Third, beware the drug that drops the pressure further. In a hypertensive patient, watch for trap answers like starting a beta blocker or pushing a strong vasodilator during shock. The exam wants you to stabilize perfusion first, so always match the drug to the blood pressure and the perfusion right in front of you. Let us work through our first practice question, and this one is built to test whether you can read volume status. A 70-year-old man with known heart failure comes to the emergency department with worsening shortness of breath over 3 days and swelling in both legs. His blood pressure is 150/90, his oxygen level is low and his limbs are warm. He has crackles in both lungs, raised neck veins, and has gained several pounds. The question asks for the most appropriate next step. Before you choose, decide whether this patient is wet or dry and warm or cold. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. Crackles in the lungs, swelling in the legs, raised neck veins, and recent weight gain all tell you the patient is fluid overloaded or wet. Warm limbs and an adequate blood pressure tell you he is still perfusing or warm. This is the classic wet and warm exacerbation, which is the most common scenario you will see. Next, apply the rule. For the wet and warm patient, the next best step is decongestion with an intravenous loop diuretic. Intravenous furosemide pulls off the excess fluid, relieves the breathlessness, and treats the real problem. So the answer is to give intravenous furosemide. Finally, eliminate the wrong answers. Dobutamine and norepinephrine are for the cold, poorly perfusing patient, not this warm one with a good blood pressure. A large bag of normal saline would make the overload worse and is the overkill trap that does the opposite of what is needed. The correct answer is to give intravenous furosemide. Here is our second practice question, and this one tests whether you recognize the patient who needs the pump supported. A 65-year-old woman with severe heart failure arrives with breathlessness and confusion. Her blood pressure is 80/50, her heart rate is fast, and her hands and feet are cool and mottled. Her urine output has dropped. She has crackles and leg swelling, so she is overloaded but barely perfusing. The question asks for the most appropriate next step. Read the perfusion clues carefully, decide whether this patient is warm or cold, and pick your answer. We will reason through every option on the next slide. Let us work through this answer. First, read the perfusion. A low blood pressure, cool and mottled limbs, confusion, and falling urine output all say this patient is not perfusing or cold. She is also overloaded or wet. This cold and wet picture is low cardiac output failure, and the pump itself needs support, not just more diuresis. Now, why does an inotrope win here? For the cold patient who is not perfusing, a drug such as dobutamine increases the strength of contraction and restores forward flow, which is exactly what she is missing. A rapid fluid bolus would flood an already wet patient. Starting a beta blocker would weaken a failing pump in the middle of shock. Sending her home with a higher water pill dose would be dangerous in a patient this unstable. The correct answer is to start an inotrope such as dobutamine. Let us talk about diuresis strategy, because the exam tests the details of how you take fluid off. First, think about dose, route, and response. Intravenous loop diuretics work faster and more reliably than oral pills in an acute exacerbation, so favor the intravenous route on the boards. A patient who is already on a home water pill usually needs a higher intravenous dose than their home dose to break through and actually make urine. Track the response by urine output and daily weight, and step the dose up if the decongestion stalls. Second, watch the potassium and the kidneys. Aggressive diuresis can drive the potassium and magnesium down and can nudge the kidney numbers upward. When a stem shows a low potassium during diuresis, the next best step is to replace it, not to stop treating the overload. And remember that a modest rise in the kidney values during effective decongestion is often acceptable, and the exam usually wants you to keep relieving the congestion rather than abandon it. Here is our third practice question, and it is all about optimizing the patient before discharge. A 68-year-old man admitted for a heart failure exacerbation has been decongested. He now breathes comfortably, his weight is back to baseline, his neck veins are normal, and his kidney numbers are stable. He has a reduced ejection fraction, and right now he is on a loop diuretic only. The question asks for the most appropriate next step before discharge. Think about what this patient still needs in order to live longer, not just feel better, and be careful not to get pulled toward an answer that does too much or too little. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, spot the therapy gap. This patient is decongested and stable, but he is only on a water pill, which controls his symptoms without doing anything to help him live longer. A patient with a reduced ejection fraction needs the guideline medicines that have been proven to prolong life started and carefully titrated before he leaves the hospital. Starting those survival medicines is the care that is actually due, so that is the answer. Now, the key distinction between the wrong choices. Coronary computed tomography angiography is the classic overkill trap, ordered in a patient who has no new chest symptoms. Keeping a stable, decongested patient admitted for another week is inappropriate and costly and exposes him to the hospital with no benefit. Discharging him with no follow-up appointment almost guarantees a return visit. Every distractor either does too much or too little. The correct answer is to start the guideline medicines that improve survival. Here is the single pearl that ties this whole topic together, and it is the wet, dry, warm, and cold framework. On your first read of any exacerbation stem, decide whether the patient is wet or dry. Crackles, leg swelling, raised neck veins, and weight gain mean wet, and that calls for diuresis. A patient who is dry and underfilled needs the opposite, so do not reflexively give a water pill to every breathless patient. Let the congestion clues drive the fluid decision. On your second read, decide whether the patient is warm or cold. Warm with a good blood pressure means keep treating with diuretics. Cold, meaning a low blood pressure with cool limbs and poor perfusion, means support the pump with an inotrope or reach for a pressor when the patient is in true shock. This simple grid, wet or dry and then warm or cold, will answer the large majority of heart failure exacerbation questions you meet on the exam. That wraps up our review of heart failure exacerbation for Step 3. Remember the core ideas we covered today. First, read the stem to decode volume status, deciding whether the patient is wet or dry and warm or cold before you choose anything. Second, diurese the wet and warm patient with an intravenous loop diuretic and save inotropes for the cold, poorly perfusing patient and pressors for true shock. Third, before discharge, optimize the medicines, starting the guideline therapies that actually improve survival and arranging close follow-up. The best way to lock all of this in is to drill heart failure questions in your question bank under timed conditions, and to read every explanation, even on the ones you got right, while leaning on a trusted review resource for the underlying physiology. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.